Let's talk a little bit now about sort of taking all of that information and figuring out what happens clinically. What do we see in actual practice? And so excess weight causes and wreaks havoc on literally every portion of the body. Me, as a gastroenterologist, I see reflux, I see esophageal cancer, I see colon polyps, which sometimes can lead to colon cancer. We see fatty liver disease. Over time, fatty liver disease without treatment, which is just weight loss, we see that turn to fibrosis, which is scarring of the liver. And over time, that scarring of the liver becomes cirrhosis. Fatty liver is now becoming one of the main issues and main reasons patients are getting liver transplants in this country. So no longer alcohol and Hep C, but now from fatty liver disease that has gotten worse over the years, which is something that is treatable with weight loss. Cirrhosis, liver cancer. Once a patient has cirrhosis, they're at higher risk for liver cancer, which is why we screen those patients every 6 months. So that's another risk once somebody has cirrhosis. Gallstones. We have a lot of patients that have had their gallbladders removed, but also other things that can happen is stones can come out and get stuck in that duct and cause you to have sort of an inflammatory sort of event called choledocholithiasis, that can make us have to go in and sort of take those stones out of that duct. So that's another procedure a patient may have to have, or gallbladder cancer, pancreatitis, or pancreatic cancer. So there's many, many things that can happen, and this is just in the GI tract. But think about sort of everything else, the neurological components with headaches and strokes, and issues with diabetic retinopathy, so issues with your vision, respiratory. People, for example, will have sleep apnea, then poor sleep. Sleep apnea can also lead to high blood pressure that being uncontrolled. Many types of cancers as well. Also high blood pressure. Know about heart attacks and high cholesterol and clotting. A lot of people will notice the joint pains with arthritis and back pains, which lead people to not move around as much. And then there's more have sedentary lifestyle. The psychological piece we've talked about with depression, anxiety, and then causing more eating disorders with emotional eating at that point. A lot of nutritional deficiencies, and we know there's a lot of reproductive problems as well that can happen and occur in the setting of excess weight. And so the question that I get from so many of my patients is, well, what is it? It must be my fault. I'm told that I would feel better if I would just lose weight. And I am told by my doctor that, I wouldn't have joint pain, wouldn't have to worry about any of these things if I would just go lose weight. And the onus is on me to just figure it out and do it. However, it's actually not quite that simple. It's not as simple as sort of that old dogma, that old thought that we had of just simply eating less and moving more. With more data and more research over the years, we've been able to determine that it's actually a lot more complicated, and that physiology of weight is more complicated than that, as we alluded to that definition we gave in the very beginning. And so I like to start with my patients because everybody is really obsessed with sort of caloric intake, right? And everybody wants to keep up with how much they're taking in, and everybody, so that's the only thing on the packages that people pay attention to is the calories. And so when I ask a patient, what is a calorie? Most of them cannot tell me what a calorie is and where it even came from, or how consistent it is, or how it affects their bodies. And so the word calorie itself, there's a lot of sort of conflict on who coined the term. And so in the 1800s, about several different scientists that have been said to sort of have been able to coin the phrase. But what it is the amount of heat needed to raise any particle of food, 1 kilogram of water, the temperature, from 0 to 1 degree Celsius. And that is sort of what a calorie is, right? So being put inside this chamber for food and seeing how much it would take to raise that temperature. And as you can see, that we are not sort of closed structures. We're not closed chambers. There's many, many variations. There's genes and epigenetics and losses with sweat and stool and urine. There's stressors. There's how we process food. There are medications we may be on. There's how much mobility. There are many different variations and reasons in which that would not sort of correlate to us specifically for every single thing. So a calorie just isn't a calorie, and a calorie is not equal across all patients or all people. And so how it was determined in like 1800s was by Atwater determined the average number of calories in fat was 9 calories per gram, and carbohydrates was 4 calories per gram, and protein also 4 calories per gram. So this is sort of where this came from. So I like to give people idea before they start harping on how their caloric intake, to just take a moment to give themselves a little bit of grace, just to think about what is a calorie and why is that important to you, and sort of how does that correlate to you in your body. So a little bit of, instead of, I try to go a little bit beyond just sort of caloric intake. And I went or a BMI in general, because we know BMI is sort of not a great measurement of sort of a patient's overall health. So we want to make sure we take into account sort of everything as we're thinking about the total patient. And so we look at body composition, and this gives us more information. This gives us information on the percent fat, the bone, the percent of water, the percent of muscle, and it gives us a better understanding of each particular patient. Some people may have a little bit more muscle, and BMI doesn't account for that. You have a higher BMI and be classified as having obesity, but technically that weight is in the setting of muscle. Some of my patients have excess water. So patients that have heart disease, like heart failure, or patients who have kidney disease or on dialysis, patients that have liver disease with a lot of fluid and ascites. These are all patients that have excess water weight, but but BMI doesn't take that into account. It takes into account, nothing. So there's several different ways to sort of determine body composition. The gold standard is sort of a DEXA scan, which is what you see here. So it's able to sort of figure out and delineate those things for us. But most people won't have that done, right? Because it's sort of an expensive way to determine sort of your percent fat, bone, water, and muscle. Other ways are also pretty sort of hard to come by. One of them is called an indirect calorimeter. And this is something I did during my nutrition fellowship, actually. But it takes a lot of things into account. It's only at specialized centers, and so not something that is efficient enough to be able to do sort of in everyday life. You have to be very still. It matters what you've eaten, what you've been doing before. So there's a lot of things that sort of correlate to that. And so this gives you an understanding, though, of exactly your predicted sort of energy expenditure every single day. So how much it takes to run your body every single day. And sort of what that prediction is. And that sort of gives us an idea of sort of if patients want to lose or gain weight, sort of what their intake they should be aiming for. And there are other things that we use as well to sort of do this. One is called a bioimpedance study. And this is a little bit easier to come by. We have one of those in our clinic. That's what we see here on the left. And this is using sort of impedance to be able to determine and look at each portion of your body sort of separately. So look at each of those compartments to determine what is happening in both legs, both arms, and that trunk area as well, to give us a better understanding of percent fat mass, visceral fat, and skeletal muscle mass. And that's a water weight as well. And then we have the BOD-MOD over to the right here, which is an air displacement test as well. And so some very high-tech ways we're sort of able to use now to be able to give us an understanding and a little bit better of an idea about body mass index and body composition itself. And so when we're talking about sort of energy expenditure, what I like to use after we're going through talking to our patients about portion control, serving sizes, sort of how much we're intaking every day, and sort of trying to pull back from sort of how much emphasis we're putting on sort of caloric intake, I want people to sort of think about how we're all very different. I think in our country, sometimes we look at the label on the side of a box and it says 2,000 calories. That's how things are calculated for an intake of 2,000 calories per day. And sort of I use this bioimpedance study to show patients that most likely you are not burning 2,000 calories a day, right? And so that's not what it takes to run your body every day, unless you're sort of an athlete or something. And so this is to give patients that understanding, because if you are thinking that that's how much we're supposed to have every day and you reduce that to, 1,800 and you're sort of get frustrated because there's no weight loss. The problem is sort of where are we starting, right? And so this sort of calculation is able to give us what patients' basal metabolic rate is. And so the one here is a little bit dark, is 1,399, so 1,400. So for a person to lose weight, they would need to be underneath that, right? In a perfect world, if we're thinking a calorie is a calorie, but to give people sort of that general idea about daily intake. But also we talk a little bit about what that breakdown is. So what is that total energy expenditure? What is made up of that? And so the large part of that is that resting energy expenditure. And that's sort of what it takes to run your body every day. Those are things that we can't really alter a whole lot. Other two things we can alter a little bit, right? The thermic energy of food is like 10%. So I tell patients it's a little bit counterintuitive, but when you're eating, you're actually burning energy as well, but you have to break that food down. So that's about 10%. And the other one is the EEPA, which is sort of how much you're moving around. So I'll ask patients to just get up and move around throughout the day. It doesn't have to be sort of a dedicated, you say, oh, I can't work out today. I don't have time. So you just don't move at all. No, I get my patients, I want you to get up and just move around throughout the day. Some people will have, if you have a very sedentary job, sort of a standing desk or a treadmill desk, or just simply parking further away. These are sort of ways, taking the stairs instead of the elevator. These are sort of easy and quick ways to sort of increase sort of how much of that physical activity you're getting to be able to burn. And I want people to get out of the habit of thinking that it has to be this dedicated hardcore 2 hours of workout. And that's the only thing that matters. No, movement in general matters. And so getting people to think about that a little bit more is also very helpful.